Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss creatinine and the estimated glomerular filtration rate, or eGFR. Like urea that we discussed in the last video, creatinine is also a nitrogenous waste product that our body eliminates so that it does not accumulate. As we shall soon see in this video, the eGFR, or the estimated glomerular filtration rate, is a very important number that tells us how well our kidneys are working. This eGFR number is calculated from our serum creatinine. In the next video, we are going to use the ratio of urea nitrogen to creatinine, what we call the BUN-creatinine ratio. We are going to divide these two to get the BUN-creatinine ratio, and the next video will discuss some of the clinical applications of this BUN-creatinine ratio. Here are some key points to focus as we go through this as well as the next video. Number one, creatinine and BUN values are used mainly to evaluate kidney function. Number two, serum creatinine is used to calculate the eGFR. Now, why do we need to calculate eGFR? eGFR, the estimated glomerular filtration rate, is very important for the diagnosis as well as staging of chronic kidney disease. And if we divide the BUN by the serum creatinine, we get what's called the BUN-creatinine ratio. And this ratio has several important clinical applications. In the next video, we'll talk about some of these very important clinical applications of the BUN-creatinine ratio. One important application of the BUN-creatinine ratio is to distinguish acute kidney injury, or AKI, that is caused by pre-renal mechanisms from acute kidney injury that is caused by either renal mechanisms or have some post-renal causes. And this is something we'll talk about in the next video. We'll also see how the BUN-creatinine ratio is very important for evaluating patients with heart failure. And also in the next video, we'll see the BUN-creatinine ratio being used for the evaluation of patients with gastrointestinal bleeding. So here is the chemical structure of creatinine. It has several tautomers. The two major ones are shown here. The amino form, you can see this is the major form that is found in water, that is found in our skeletal muscles or in our water, in our body water. And the other form is the imino form, shown here. You can see from these structures that it is very rich in amine groups. And the normal serum creatinine in a healthy individual, you can see, is about 1 milligram per deciliter. And as we mentioned earlier, the major use of creatinine is to evaluate our kidney function. As we did in previous videos, in order to understand the reasons why our serum creatinine can be elevated or can go down, we need to understand the ODME of creatinine, that is the origin, distribution, metabolism, and excretion of creatinine, basically the life story of creatinine in your body. So the origin of creatinine, where does the creatinine that we see in our serum, where does it come from? Well, one source is the diet. Cooked meat has creatinine. The other source is from the muscles. You can see creatinine is made by the spontaneous conversion of either this chemical creatine in muscles or phosphocreatinine in muscles. So creatine can give you creatinine, phosphocreatine can give you creatinine, and creatinine can also come from the diet. So since most of your creatinine in the serum comes from muscles, from creatine or phosphocreatine, the next question would be, where does this creatinine or as well as phosphocreatine come from? Now, creatine can come from the diet. Meat as well as seafood is very rich in creatine. Not plants. Plants don't have creatine, so if you eat meat or seafood, you can get creatine from your diet. Besides the diet, our body can also synthesize creatine. In the kidneys, we have an enzyme called arginine glycine amidinotransferase, and this enzyme catalyzes the reaction between the amino acid glycine and the amino acid arginine to give us the product guanidinoacetate and as well as ornithine. The guanidinoacetate is then transported from the kidneys to the liver, and in the liver there is an enzyme called guanidinoacetate and methyltransferase, or GAMT, and this enzyme basically methylates. You can see the addition of a methyl group using SAM as adenosyl methionine, and this guanidinoacetate is converted into creatine. So creatine can come from the diet as well as synthesis in the body. The creatine is then transported from the liver to various tissues, especially the muscles. In the muscles, about 70% of the creatinine is converted into phosphocreatine. This reversible reaction between creatine and ATP to give you phosphocreatine and ADP is catalyzed by the enzyme called creatine kinase. In a future video, we shall discuss the importance of creatine kinase in myocardial infarction, also called a heart attack. Every day, about 1 to 2% of the total body creatine as well as creatine phosphate is spontaneously converted into this compound called creatinine. And the amount of creatinine that then leaves the muscles and enter the bloodstream is fairly constant, and it really depends on the mass of the muscle. Okay, so the next part of the life story of the origin is distribution. How does creatinine travel in your bloodstream? Now, creatinine is very water soluble. So remember the concept: if the chemical is very water soluble, it simply dissolves in the water part of the blood, and it does not require any protein to transport the chemical. So like glucose, creatinine simply dissolves in the water and travels in the bloodstream to every part of the body. Metabolism of creatinine. Creatinine is a nitrogenous waste product, just like urea. So it's not used by the body, it's simply excreted by the kidneys. Excretion of creatinine. Creatinine has a very low molecular weight, 113, so it's readily filtered by the glomerulus. Remember, the cutoff is about 40,000 or 40 kilodaltons. So anything that has a molecular weight less than 40 kilodaltons can very easily go through the glomerulus and enter the proximal convoluted tubule. About 10 to 20% of creatinine is also secreted from the bloodstream directly into the proximal tubule. This creatinine then travels through the rest of the tubules and eventually comes out into the urine. So note that unlike urea, creatinine is not reabsorbed. It is filtered and it is secreted, but not reabsorbed. Now, the excretion of a chemical by the kidney involves 3 steps. So one is filtration from the bloodstream across the glomerular filtration membrane into the tubules. The second is secretion, where the chemical goes from the bloodstream directly into the tubules without going through the filtration membrane. And the third process is reabsorption, where the chemical in the tubule is reabsorbed back into the bloodstream. For creatinine, there is no reabsorption. Creatinine is not reabsorbed at all. The secretion part is negligible, only 10 to 20%. So basically for creatinine, we are talking only about filtration through the glomerular filtration membrane. So since the amount of creatinine that is entering the bloodstream is fairly constant, and creatinine basically goes through the kidneys only by filtration, so for that reason, creatinine is a good marker for the glomerular filtration rate function of the kidney. So clinically, why do we need the glomerular filtration rate? The reason is because the GFR defines kidney function. Basically, kidney disease is associated with decrease in GFR. The more severe the kidney disease, the less the GFR. So the severity of the kidney disease is inversely proportional to the GFR. In case of healthy kidneys, the GFR is roughly about 125 mils per minute. So as kidney functions declines due to diseases or whatever reason, it makes sense that the excretion of creatinine as well as urea will go down. And when the excretion goes down, that means the concentration of these chemicals, creatinine and urea, will increase in the bloodstream. Now, although clinically creatinine is used as a marker for GFR, we should remember that neither creatinine nor urea are ideal markers for GFR. And one problem with this use of creatinine is that it is not sensitive. So the GFR must decrease by almost 50% before the serum creatinine or before the BUN increases. Between the two, creatinine and BUN, urea, creatinine is preferred because it's more specific than urea, since urea is affected by several non-renal conditions where the creatinine is normal or just slightly increased. So since GFR is related to kidney disease, it's not surprising that clinically one of the things that tests that we do is this what we call estimated glomerular filtration rate, or eGFR. There are several ways to determine the GFR. One of the earliest is called the creatinine clearance test, CRCL. To determine the creatinine clearance, we need to know the creatinine concentration in the urine, the U part here. The P part here is the creatinine concentration in the plasma. We also need to know the urine flow in mils per minute. That's the V part here. So this test, creatinine clearance, requires a urine sample collected for 24 hours. So when we say a person has a creatinine clearance of 94 mils per minute, it means the person's kidneys are completely removing creatinine from 94 mil of his or her plasma per minute. So the problem with this test is that it's inconvenient to collect urine over a 24-hour period. So due to the inconvenience of collecting urine from a person for one day for 24 hours, scientists have come up with different formulas for calculating the creatinine clearance. One of them is shown here, where you simply need serum creatinine concentration. So from the age as well as the weight of the person and the serum creatinine, using this formula, we can calculate the creatinine clearance. Clinically, creatinine clearance is used for medication dose adjustments. And the reason for this is because the FDA recommendations are actually based using creatinine clearance. Note that the creatinine clearance is actually higher than the actual GFR, 10 to 20%. That's because about 10 to 20% of the creatinine is secreted. So not only is creatinine filtered, there is 10 to 20% that is secreted, and that's the reason why the creatinine clearance is actually going to be higher than the GFR. A popular method to determine the glomerular filtration rate, which is part of the comprehensive metabolic panel used by a lot of hospitals, is this formula, that is the CKD-EPI formula of calculating or estimating the glomerular filtration rate. This CKD-EPI formula is shown here, and you can see that it requires this SCR, and SCR stands for standardized serum creatinine in milligrams per deciliter. Standardized here means that the creatinine assay is standardized using isotope dilution mass spectrometry calibrators or standards. So although this is the most popular equation to determine glomerular filtration rate, it should be noted that creatinine clearance may actually be more accurate in people with very large muscle mass, such as bodybuilders, or in frail, malnourished individuals with very small muscle mass. Besides creatinine, there is another marker for glomerular filtration rate, and that is cystitin C. This cystitin C is a cysteine protease inhibitor. It is a small molecule, 13,000 molecular weight. It's secreted by all nucleated cells, especially macrophages and dendritic cells, at a constant rate. Now, in the cell, this protease inhibitor inhibits lysosomal proteases. Once it's secreted, it inhibits extracellular proteases. Recall that proteases are basically enzymes that break down proteins. So this cystitin C has a low molecular weight, 13,000. So remember the cutoff is 40,000 for filtration. So it is very freely filtered. It is completely reabsorbed and then catabolized by the proximal renal tubular cells. So just like creatinine, as the kidney function declines, the serum concentration of cystitin C rises. Now, the nice thing about cystitin C is that it's not affected by muscle mass, not affected by age, sex, or diet. So one of the best tests for estimating glomerular filtration rate is a combination of cystitin with creatinine. That's called the CKD-EPI creatinine cystitin equation. Okay, so now let's discuss the common causes for high creatinine. And whenever possible, we'll try to compare that with BUN so that you better understand the BUN creatinine ratio that we'll discuss in the next video. So just like any other chemical, the blood concentration of creatinine can increase either if there is greater input into the blood, more of the chemical is coming into the blood, and or less of the chemical is being eliminated from the bloodstream. So either of these two or a combination of these two processes can lead to increase in the concentration of serum or blood creatinine. Now, clinically, the most important reason for why blood creatinine increases is because of the decreased output. There is less elimination of creatinine from the body, and that's because of either acute or chronic disease. And that's basically the same for BUN. Now, there are also conditions that can increase the input, add more creatinine to the serum, and these include things like a high GI protein intake, because proteins have not only creatine, but when you cook the meat, the creatine is converted into creatine. So a high protein intake can increase both your creatine as well as creatinine. Since most of the creatine and creatinine is in the muscles, anything that causes increased muscle breakdown, such as strenuous exercise or the breakage of muscle cells in rhabdomyolysis, that can release creatine as well as phosphocreatine that can then be converted into creatinine, and this can eventually enter the bloodstream to increase the serum creatinine levels. And of course, nowadays supplements, people who take high amounts of creatine, that can increase blood creatinine levels. In case of urea, just to remind you, high GI protein intake can increase BUN, as well as any condition that increases protein catabolism, such as trauma, starvation, surgery, and so on. All that can increase your BUN. Now, an important point to note is that in chronic kidney disease, the creatinine concentration remains elevated, while in acute kidney disease or in any of these other conditions here, the creatinine levels temporarily increase, but eventually they will come back to normal levels once the condition subsides. So as mentioned earlier, the most important clinical use of creatinine is in kidney diseases. Now, just to remind you, serum creatinine as well as BUN, these are not sensitive indicators of disease because they only increase in the serum after about 50% of the kidney function is impaired. So since we have two kidneys, this serum and BUN may not increase until both kidneys are affected, because one of the kidneys may actually enlarge and compensate for the other damaged kidney. So as mentioned earlier, serum creatinine is used to calculate this eGFR, and this eGFR is very important for the diagnosis as well as staging of chronic kidney disease. So CKD is diagnosed if either of this is present and persists for more than 3 months, either number one, where the eGFR of the patient is less than 60 mL per minute per 1.73 meters squared of body surface area, or these markers of kidney damage are present. And these markers include things like presence of albumin in the urine, what we call albuminuria, abnormal urine sediment, such as the presence of red blood cell or white blood cell CAS, or red blood cells that are distorted in the urine, the abnormal electrolyte concentrations, abnormalities in biopsies, structural abnormalities detected by imaging, as well as a history of kidney transplantation. And this table shows you how the GFR is related to the stage of the chronic kidney disease. So in the earlier stage 1, the GFR could be 90 or higher, but as the kidney function goes down, as the disease progresses, we reach stage 5, where there is basically kidney failure, and at that time the GFR goes very, very low, less than 15, and in this case the patient may need dialysis or transplant. What about low creatinine, or what are the common causes of low creatinine? Malnutrition or vegetarian diet, where people don't eat meat because, as mentioned earlier, meat has creatinine, as well as cooked meat has creatinine, as well as meat. Vegetarians in general have lower muscle mass compared to meat eaters. Another reason one can get low creatinine is liver disease, because as we mentioned earlier, creatinine comes from not only the diet but also synthesis by the liver. Anything that causes reduced muscle mass, so for example aging, as we age we lose muscle mass, that will reduce the amount of creatinine, that's called sarcopenia, or any disease where there is muscle wasting, such as muscular dystrophy, that will reduce the serum creatinine levels. Now, in pregnancy, there is an increased GFR, and that will eliminate creatinine faster than usual, and that will also lead to lower creatinine levels in the blood. And in comparison, for BUN, once again, malnutrition, low protein will lead to low BUN, severe liver disease because urea is synthesized in the liver, and once again, pregnancy will lead to lower BUN. Okay, so this is a little bit about creatinine. In the next video, we shall discuss the BUN creatinine ratio. So until the next video, once again, thank you very much for watching and supporting this channel, and have a wonderful day, and we'll hopefully see you in the next video.